Good evening. My slides are visible.
Yes, Revanth, they are visible.
We'll start and finish this. The first topic is alarm settings and troubleshooting. And if you people are already doing some amount of mechanical ventilation using ventilators, so how many times you feel that these alarms are causing much noise, and I think they are very useless for us. We will just go and just silence the alarm and we'll do the work. So many of you are you really go and check why is alarming and what is the problem, whether we need to do any troubleshooting for that alarm or not. I did the same in my PG. I'll go shut the alarm down and I'll come back. I'm not bothered about why the alarm is ringing. Someone put that alarm wrong, so it's shouting. So we'll just silence it and come back. Is it the norm for all, or there are people who think alarms are very important? It's not just a ventilator alarm, it can be your vitals monitoring alarm also. So why alarms are very important?
Any disconnection with them?
This is what we usually in interns and first year PGs will feel. So I think many of you don't know Tamil, it is in Tamil. So here an intern is asking a senior PG consultant. So ventilator is giving an alarm, can I go and see? So answer is start whether you know why it is alarming, you know any CMB or SIMB modes. Then he told, why I should know all these things. I just should know how to silent it. I can go and silent it. I can off it. So that is what the feelings of many of us during initial days of our ventilator practice. And I'm not an exception for this. So only after knowing why it is important, then only we'll realize what is that. So I don't think many of us, when you're starting mechanical ventilation, we check that alarms or we set the alarms. You feel that you have to set the alarms, or ventilator will give the ready-made settings for the alarms. How many of people know that you need to set the alarm?
We need to set the alarm.
As many of you doing that? Tell honestly. It's not like we are doing wrong, because we have to learn every day. I learned in my PD days and early consultant days, I never bothered about alarms. Never. But later on, I realized that alarms are very important. So what I need to know is that if you're not doing that thing as a part of initial settings, like yesterday we discussed about how to start the ventilator. As you're setting FiO2, as you're setting Peep, as you're setting PAP or tidal volume, as you're setting respiratory rate, from today onwards, you need to make an habit that you are going to set the alarm settings as well simultaneously. It is not like that you set the ventilator, you do other works, you see the response of the patient. It's not about just seeing the response on the patient. Simultaneously, once you got the response and child is able to maintain adequate saturations on the ventilator, you need to set the alarms as well. And whenever you're going to change the settings based on your O2s and CO2, you have to open the alarm page and you need to change the alarm settings as well according to the current settings. It's not like universal settings for any patient. It is only based on the current settings, you need to change the alarm settings as well. So that is what you need to learn from today's class. So because many times we feel that when ventilators are alarming, it is a headache. Why this is alarming? But you should know that alarms are just to warn you that there's something which is not normal, or something is going to happen with the child. So that's why always take alarms seriously. Go check it. Once you check everything and you feel that okay, this is alarm is because of we not set the settings properly, or there is something child is moving, or child is getting agitated, then we'll try to calm him down, or you set the alarm, change the alarm settings, then you make sure that there's nothing wrong with the child. Then only you need to relax. It's not that you just go silence the button and you do the most important one. Even ventilator alarm assessing and identifying the problem and treating is very important job. It is not just putting on the ventilator, getting the ABGs, changing the settings, but it's also you need to address the ventilator's alarms carefully. If you people are setting the alarms correctly, I need to know the people who are setting alarms. I just want to ask them, what are all the alarms you're going to set and what are the settings you're going to use?
Pressure.
Minute ventilation, respiratory rate.
Minute ventilation.
So minute ventilation, respiratory rate, pressure. What pressure? What pressure alarms you are setting? PIP or PEEP?
PEP.
So only PEP. You don't want PIP. You want PIP or you don't want PIP? How many of you feel I don't want PIP alarm? First of all, why alarms are needed? What is mainly this alarm things and all?
Desired pressure is not.
Desired pressure is not delivered. Okay, why it is not delivered? You set the bed pressure, it is going to deliver only. It is never, it is not going to deliver until unless there is an issue with something else.
If there is any disconnection, we can know, sir. If the
Oh.
compliance is increasing or decreasing,
Yeah, that's what I'm
there-
asking. How you know?
sir, if compliance is decreased, more pressure is needed, sir. So automatically ventilator will increase the pressure.
Automatically ventilator will increase. Then what is the point of giving alarm then?
Yes, sir, we can set a limit, sir, so that we can know when it is increasing. We can.
So what you're going to set here then? Which pressure you're going to set here? Which
Inspirate
alarm?
peak inspirator.
Peak inspirator pressure. Yes, exactly. If you ask me, what are the two important ventilator alarm settings I must set? One is PAP, other one is minute ventilation. That's all. If you're able to set these two things correctly, that means you have done the job. Remaining things are all okay, fine, leave it. They are not very much important. But setting a PAP alarm and setting a minute ventilation alarm is must. So if you people are setting PAP alarm, how to set PAP alarm?
10 above the
10 above the?
whatever we are setting the pressure, sir. About the 10 extra will.
Okay, in pressure control mode, you're going to set pressure, but in volume control, how you will know? In pressure control mode, if you set PAP alarm also, what is the use? Does it is going to cross that?
No, sir.
Then how set in volume control? In volume control, how to set the PIP alarm? I am not talking about it because you don't have any control over PIP in volume control. Just think, it's not very. I'm not asking anything extra or what we cannot answer, but it's just logic I'm asking. So alarms are there to tell you that is there any change from baseline. So I already given the clue to you. The main purpose of alarms is to let you know that there are changes from baseline. That's all. So now you have to tell me how to choose PIP alarm in volume control mode. I already given answer.
We know the normal values for the patient, sir. Depending upon that, we should see the condition of the patient and then.
Depending on the condition, your PAP will be changing. So it is not like lung or abnormal lung. Depending on the underlying lung, your PAP is going to change. You cannot have like normal CPIP of 15 or 20, 25 for this particular child. So what you're going to set in volume control?
Sir, minimum
Yeah.
5 above and maximum 10 above.
That's how to know that 5 above. You should know that how much pressure. Then you need to know the 5 above. How to know that how much pressure? This is the baseline for this child. How to know? So you need to set alarms to that particular point. That's what I'm telling. So at this moment, like say 7 o'clock, I put the child on ventilator. I put him on volume control, and my volume I set is around 6 ml per kg. For getting 6 ml per kg, he is needing a PAP of 25 at this moment, at this 7 o'clock. So what is the PAP you need to set on the alarm? So you need to set, like you told, 5 or 10 above the baseline PAP. The baseline PAP here for this child at this moment of 7 o'clock is 25. Is it clear what I'm telling? So the setting of alarms is to be individualized. It's never, these are the settings I need to set. This is never for age group. This is never for like underlying lung disease. So setting of alarms is not related to any underlying lung disease. It is not related to any particular age group. It's never to be generalized. It is always to be individualized to that particular child and to that particular point, because your lung will be changing point to point, like it's dynamic. Morning it could be like this, afternoon it can be like this, evening it can change, it can worsen, it can improve. So based on that change of your normal set parameters or set not set conditional variables, like we set the tidal volume pressure is changing. With the changing pressure, automatically you need to change your alarms. You cannot keep the same alarm from starting of ventilation to extubation. No, it is not like that. So you sometimes every hour you have to keep changing the alarms. Like if you have an asthma ventilation and you are giving nebulizations and your child is getting better, you should come down on the pressure alarms because the PAP is coming down. You cannot keep the same PAP of 40 or 50 what you kept initially, and now the baseline PAP touching 20. You cannot allow the pressure alarms to be there at the 40. That's what I'm telling. Alarm settings to be individualized. It never be like this. Okay, for this child is the normal, I'm going to set this. It's not like that. This is from the baseline settings, and the baseline settings could be changing every hourly, every shift, every day. So you need to keep changing the alarm settings according to that particular baseline settings at that particular point. Is it clear what I'm telling now? This is very important.
Yes, sir. Yeah.
Because many times I've seen that there's a set alarm settings for throughout the ventilation. Like you ventilate for 3 to 4 days, the settings are same. No one is bothered to touch that. So that is wrong. As you are just checking daily that either any improvement in settings, whether pressures are coming down, pressures are going up, simultaneously you need to go and open the alarm settings and whether alarm settings at this particular moment are correct or wrong. So this is what you need to do. You shift rounds or daily rounds, whatever it may be. You need to keep changing your alarm settings according to the changing lung. Then only you can get a correct alarm. If you don't do that, you will get the false alarms. And sometimes what you will do, you will come check 2 to 3 times. You don't have to figure out what is the problem. You tell child it's normal, it's alarming unnecessarily. And finally, you keep switching off the alarm, silencing the alarm. It's like Aavu Puli Katha. So many times they will tell, the child will complain, is Puli coming, and finally when the grandfather will check, there's nothing, and finally when real tiger comes, he will not come back. So it's like that. So if you're not able to set the alarms properly, you're going to miss the real event. So be careful and keep it a point like this. So you need to go and check the alarms every time you go see the ventilator. You need to see whether I need to modify the alarms or not. That's all. Along with the you are noticing that whether pressure changing or minute ventilation changing or not. So simultaneously you need to check whether alarm is set correctly or not. That's important alarm setting, sir. Because we'll know if alarm is going to give the thing. So what you need to do exactly. So for that baseline, so you need to set the pressure at least 10 above the set or current PIP. So this is what you need to going to do. So usually you won't set low pressure alarms. The MACAT ventilator doesn't have any low pressure alarm because it's not that useful for us. So many other ventilators will have low pressure alarm also, but in MACAT they've taken off low pressure alarm. So it's not that useful because really we don't come very rarely and very rarely we're going to get a low pressure alarm, and we'll see which situation we can get that. Usually we'll get high pressure alarm with the worsening lung or mainly with the tube blocks. So tube blocks due to secretions, your airway resistance increases. So that's why your PIP goes up. So that's why you really get a PIP. That is the alarm. You need to be very careful and you need to go back and check whether there's a tube kink or your secretion pulled up. You need to do suction, and if it's still everything is normalized and pressures are not coming down, then you will think whether lung is worsening or the child had a pneumothorax. This kind of things you need to rule out. So that's why a high pressure alarm is very important. We'll see how to troubleshoot the alarm. And respiratory rate, you need to keep plus or minus 10 over the set respiratory rate. And in spontaneously breathing patients, you need to set a little higher. So you need to match him how much he's taking. If you set alarm you need at this moment child is breathing at a 40 rate, you need to set your alarm around 50, above 50 and below like it's 30. And sometimes how the child spontaneous breathing rate came down to 35 or 30, then you need to adjust your settings accordingly. And minute ventilation, you need to set 20% from the setter current MB. So in volume control, you already set the tidal volume and rate. So your minute ventilation is constant. But in pressure control, so your minute ventilation will be little bit altering with the your underlying lung. So but at that moment, like at 7 o'clock or at 8 o'clock when you're setting the alarms, the minute ventilation will not alter that much frequently. It will be fairly constant. Like you're then going to get 5 to 10 ml changes in tidal volume with each breath, not more than that if the lung is at that moment is static. So based on that minute ventilation, what you are generating at that moment, you need to set the alarm. Say your tidal volume, you set tidal volume for an 10 kg child around 60 ml. And your minute respiratory rate is 30. So how you are going to set the minute ventilation alarm? Tidal volume is 60, your rate is 30. And now how you are going to set your minute ventilation alarm? Upper limit, lower limit. Or because yeah,
360 ml above the
2 liters.
how much ml?
360.
360 ml above. What above? I need to get the numbers.
Minute.
I have a number. What is the upper number? What is the lower number? I don't know. I am very poor in maths. So how many liters you are getting minute ventilation?
So 1.8.
2 liters, 1.8 liters per minute.
Yeah, it is 1.8. So how to set lower alarm? How much is the lower alarm here?
Minus 20%.
How much?
1.8.
1 point?
Sir, 1.4.
Yeah,
1.2.
exactly.
One-
So
1.2.
1.4, upper alarm is
2.1.
2.2 something. So 1.8 into like 0.36, you cannot give 0.36, so you need to make it 0.4. So 1.4 and 2.2. So now you people understand what I'm talking about, what is 20% means. So that is what you need to set in a minute ventilation alarm. And finally, FiO2, you need to set FiO10 above the set FiO2. And Peep plus or minus 2. That is a standard what you're going to use for Peep. So is it clear? This is the most important slide. So this is what you need to stick in your near the ventilator, and you need to make sure that your sisters also know this. This not only you should know, your staff should know this. So they are the one who is going to stay at the bedside. So they are the one who should monitor this, whether the alarms are correct or wrong. So make an effort to train them as well. It's not only about this is your job, and this is their job as well to check for the alarms. And it's very important because sometimes you are not there, they're ringing the alarm, and they are the one who is going to attend it. So that's why educating the staff is much more important in this alarm settings and troubleshooting. Okay. So in volume control, if you have a worsening lung, what is the first thing you're going to get? In pressure control, if you have a worsening lung, so or block in the tube, so what is the first alarm you're going to get?
Low tidal volume.
Whether you get alarm first or you get low saturations on the monitor alarm. You get alarm.
Low pressure.
No. First question is, when you have a tube block or worsening lung, you get an alarm on your vital monitor first or on the ventilator first. Like lowest
Ventilator.
Vital monitor.
Ventilator.
When you miss the ventilator alarm only, you are going to get the alarm on the monitor, your vital monitor. So many times we'll pick the SpO2 low SpO2 alarm rather than picking other alarms on the ventilator. That's what usually I see also. It's not I am an exception from this. So I don't want you people to do the same thing. So from today onwards, you should not see any low SpO2 alarm for a ventilated child. Until unless it is an acute deterioration, you should not encounter a slow drop in saturations when you there at the bedside. So you should never miss a ventilator alarm. If you don't set the alarms properly, you will see the desaturation alarm on the vital monitor. That's all. If you set the alarms on ventilator properly, until unless it's acute deterioration of a child, you will never get a low SpO2 alarm. It's 100% true. If you are getting a low SpO2 alarm for a ventilated child, that means you are not set your ventilator alarms properly. Next question is, so you have a volume control and pressure control modes. You have ventilated 2 children, and both the children lungs are worsening, or both of them had some amount of tube block by secretions. So now in volume control, what is the first alarm you get? In pressure control, what is the first alarm you're going to get? Volume control.
Control PIP in minute. Pressure control minute ventilation.
Exactly. So because in pressure control, your pressure is not going to increase at any cost. You already set it. The lung is worsening, there should be a drop in tidal volume. Same thing in volume control. So the ventilator tries to increase the PIP to generate the tidal volume. So, but once it reaches the set tidal set pressure, like you set it around 10 above the PIP, when it start crossing that, it will not increase further. The ventilator will not increase the pressure further what you set. Then only your tidal will start dropping. Initially, when lung is worsening, the ventilator will adjust by increasing the pressure to generate the tidal volume what you set. But only when it crosses the set PIP, it will not cross beyond that and will start alarming because it is not able to generate, not able to increase beyond that PIP. Then only your tidal volume start falling. That's why in volume control, easily you can miss the initial tube blocks, mild tube kings, or worsening lung. If you don't, come and check whether what is the PIP previously, what is the PIP now. So make sure you have a habit that When you come back near the patient, always check what the tidal volume getting generated, what the even without alarm, that's what I'm telling. It's not every time you need to come and check only when it's an alarm. Even like 8 o'clock, you see the child, the PIP is 25 in volume control. And 9 o'clock or 10 o'clock came back to rounds. You are seeing that PIP went up to 27 or 28. Then also you need to think why the PIP gone up. Whether it's because of the secretions or because of worsening lung, what is something. So there we have to recognize there is something going abnormal with the child. Not when the alarm gives. But in pressure control, same thing, you need to check the tidal volume. At 7 o'clock, my tidal volume on the same settings is 70 ml. At 9 o'clock, when I came back to rounds, the tidal volume dropped from 70 to 65 or 64. Even then, you need to check what is wrong with the child. Whether it's secretions, whether it is lung worsening, you need to make sure that you already addressed it. If you do this thing properly, you will never encounter a desaturation alarm on a vital monitor unless it's acute event happened like pneumothorax or tube displacement. So that is what. So that is important. In like monitoring is very important for us to prevent all these things. So it's not exception. It's everywhere because of the busy work hours. We're not concentrating much on this. Whether this child is okay, is maintaining all the vital. The most common mistake is we'll see the monitor, vital monitor. We won't bother about the ventilator monitor. That's the main common mistake. In ventilated child, you have to make sure that as important as you are giving to the vital monitor, you need to give the same importance to the ventilator monitor as well. So vital monitor, you can easily get heart rate, SpO2 in the normal range or not. But same times you need to check in the ventilator also what are the pressures previously, now what are the pressures, what are the tidal volume previously, what is the tidal volume now. And you should not wait for the alarm to get. Like what you see on the tidal volume, vital monitor where previously stats are 100%, now it is came to 94, 95. Okay, why is stats are dropping? So I need to take an action. Like same thing, you need to do the action for ventilator alarms as well. So this is what the sequence of events going to happen in volume control, and the same thing is going to happen in the pressure control. You have one step less in pressure control. So easily you can get the problem in pressure control. That's why many consultants won't prefer pressure control because they are busy with some other work. So they don't able to sit at the bedside to monitor the child. So because of that busy schedule, they prefer volume control because they'll get some time. So before the child going to show that alarms, so they will get some more time. So that's why they'll prefer. It's like office mode. So when you're busy, you just put them on the volume control so that you'll get the extra time for the if any little deterioration or a little worsening. But when you are on bedside, so I choose pressure control mode or volume control because I need to know the real-time status of the child. So whether the child is stable, becoming worse, or improving, so that I can know that. So now we got a high pressure alarm. So what could be the reason for high pressure alarm? Yeah, what could be the reason for high pressure alarm?
Secretions blockage.
So secretions blockage, only one thing.
Airway resistance.
Yeah, how airway resistance increases? Edema. Why suddenly edema? You are already put the ED tube inside. So how is it going to change the resistance now? Even with edema. No? But spasm. Yeah, when you're ventilating asthma chair, your bronchospasm can worsen and it can cause increased pressures. But most importantly, it's not only resistance. There's other problem as well where you need pressures. Yeah, the problem here is two things. Whether I'm dealing with increased resistance or whether I'm dealing with decreased compliance. That's all. When my ventilator is showing high pressure alarm, there are only two things which can cause this. One is high resistance, one is low compliance. High resistance is due to what blocks? How? Two blocks. Yeah, it is pulling off secretions in the ET, which is causing the block, or it is the kinking. Many times it will be the kinking. So you don't just check it properly. So ET tube might be very long and it has kinked, and you should have covered the child with some bed sheets, everything, and you just forget on that. Or in an active child, it could be a biting. So he'll be biting the ET tube as well. So that can increase the resistance. It can increase the ventilator pressures. And when you're ventilating an airway child, it could be due to worsening of your airway problem as well. So bronchospasm is worsening. But most commonly, it is because of your secretions, tube kinking, biting. That's all. This is the most common things. Because for bronchospasm, we've already been covering with the nebulizations, drugs, everything you're giving. It's very rarely a child is worsening after starting treatment. Then high compliance and low compliance. So low compliance could be worsening what are the underlying problem, or there is a element of pneumothorax. You should not forget about pneumothorax. If it's a sudden events, sudden rise in peak pressures, you must rule out pneumothorax.
VAP, sir.
Which one?
Ventilator, sir. Pneumonia, sir.
Yeah, that's what. It's a worsening lung condition. But whatever the underlying lung is, it's worsening. The parenchymal problem is worsening. It could be due to underlying worsening of the pneumonia itself or add-on pneumonia like VAP. It's going to develop slowly. So just remember these two conditions and how you should figure it out. Whether it's a problem with the resistance or it's a problem with the compliance. Because once you figure it out, you can do the necessary corrective steps.
Flat tube.
Peep requirement will be.
Someone told the answer.
Flat tube pressures.
Yeah. Can you explain it better way?
Sir, if the difference is more, sir,
Yeah.
then it is due to airway problems.
Exactly. So always troubleshoot with the ventilator itself. Don't go disconnect, do the suction. Okay, secretions are not there. Okay, now it is low compliance. Leave it. Don't do that thing first, because you need to make sure that what you're dealing exactly, when your ventilator is able to show you what is the exact problem there, you should figure it out from the ventilator first. So just you need to do is when alarms, you are getting high pressure alarm on the ventilator, just put the inspector hold button. Within 2 to 3 seconds, you'll get the answer. It is showing more difference between P plateau and P peak. I'm dealing with airway resistance, whether good secretions, do the suction, when a child is biting the tube, or there is worsening of airway bronchospasm. So this is what you need to figure it out. If you P plateau and P peak difference is normal, then it's most likely the worsening of the lung condition. There you don't need to do the suction at all. When you see that there's no much difference, there's no point of doing suction. You need to figure out what is happening. You need to auscultate whether it is pneumothorax or not, or it is just worsening of the lung. So that's what I'm telling you. When it's not like universally when you are getting high pressure alarm, you need to open, do the suction, then you decide about what are the problem there. So it's good only if you do the suction, but first you need to figure out what is the problem exactly, whether the airway problem or it is the parenchymal problem before you do all the necessary corrective steps. Is it clear? So when you get high pressure alarm, what is the next step you have to do? Ventilator is showing high pressure alarm. You went near to the ventilator. What is the next thing you have to do? Come on.
Peep and Peep.
Able to get it? What do you have to do when you go near to the ventilator to address this high pressure alarm?
We need to know whether it is because of resistance or
How you know?
delta.
What you have to do? What button you need to press? Be very clear in the answers. So you need to press the inspector better alarm, inspector hold button alarm. That's button. That's all. That's the answer I need. When the moment you reach the ventilator to check the pressure alarm, the next thing, immediate thing is you need to push the inspector hold. You wait for 2 to 3 seconds. Once you got the P plateau, okay, so what is the difference? Then you decide what to be done. Whether it's a problem with the resistance, it's a problem with the compliance. You need to do the necessary control steps. Clear? So now you got a low minute volume alarm. So what is the problem? What are the problems which can cause this? Can you get low minute volume alarm without high PIP alarm in volume control mode? Just clearly listen my words. Can you get low minute volume alarm in a volume control mode without getting high pressure alarm?
If tube disconnected, then
Yes, leaks. When you have leaks, without getting high pressure alarm, you can get low minute. So don't think that when you're getting low minute volume alarm in volume control without pressure alarm, how could it be possible? The pressures are not increasing, why I'm getting low minute? It's a false alarm. The ventilator is not working properly. Okay, we'll switch on the silence the alarm. It's not like that. So you need to always think that you can get low minute volume alarm even on volume control without getting high pressure alarm. The reason is leak. So whenever you get low minute volume alarm, you need to look for the pressure. That's the first thing you need to do. How are the peak pressures? If lung is worsening or say it's a tube block, how will the peak pressures?
increases.
When you have air leaks,
Pressure increase.
pressure will decrease actually, because the air is easily can move out. The ventilator will give the tidal volume like that, and you don't need to do much work for that volume to be vented. So in leaks, you don't need pressures, very high pressures, like previously what it is going. Pneumothorax will not come under leaks. Pneumothorax is the lung issue. Leaks is for the tube or ET tube or some disconnection from the temperature probes from the ventilator circuit. The leak is from the circuit, not from circuit or ET tube, not from the lung. So low tidal volume, you need to check the peak pressure. If peak pressure is high, then you need to troubleshoot like previously. If you have peak pressure low, so then you need to look for the air leaks. So whether it is a leak from the ET tube or whether from the leak in the circuit or already that is disconnected. ET tube and the circuit is disconnected. So it is what you need to troubleshoot in the low tidal volume or low minute volume alarm. And the next thing is decrease in respiratory rate alarm or increase in respiratory rate alarm. So increase respiratory rate alarms. So you need to see whether you adequately set the trigger. The most important problem when the child is having a low respiratory alarm, that child, some of them given sedation or some nurse came and given paralysis, or you not set the trigger appropriately. So the previously child is able to generate some amount of triggering, but now the child is exhausted and he is not able to generate the that much amount of trigger to ventilator to detect it. So that's why you need to come and change your sensitivity. You need to just see whether there is a spontaneous activity on the ventilator graphics. So in ventilator graphics, you can easily figure it out whether a child is having spontaneous activity or not. So there will be deflection on the flow curve or deflection on the pressure curve. It will be shown in orange color. The child is triggering, the color will be different from the red and blue color or green color, whatever the ventilator showing. It will show the orange color triggerings. Whether you set in the pressure trigger or volume or flow trigger, if you set the flow trigger, the orange color, the initial orange color, the tip or starting of inspiration will be seen in the flow curve, or in the pressure curve, you need a deflection on the negative side from the baseline peak. So always look for that, whether you are able to get the trigger correctly or not. And if respiratory rate high, you need to look for a leak. If you have a leak, automatically it can auto trigger. As the water in the circuit, the movement of the water can trigger auto trigger, and also look for the secretions. So these are the things you need to troubleshoot when you have high or low respiratory rate alarms. And the most important thing is, so when you have a patient with acute deterioration, acute or chronic deterioration or slow deterioration, how to approach that child. So any child with on-mechanical ventilation having respiratory distress and child is at the point of immediate cardiorespiratory collapse, so what you have to do? Loudly?
Dope.
Yeah. What is dope?
Bagging, dope.
Displacement.
Displacement, obstruction, pneumothorax,
Placement of
equipment.
pneumothorax equipment. Okay. So how to perform dope? How will you perform dope? How you will know that
There
this is equipment failure or displacement obstruction? Yeah, someone
if unstable, disconnect from the ventilator and start bag and mask.
good. So it's why you are doing this? Why you want to disconnect the ventilator and do bag and mask? Why you cannot troubleshoot on the ventilator itself?
We can know the lung compliance or resistance.
Okay. It's
At a time, we can test lung. With the test lung, we can check it. In meanwhile.
So by immediately removing from the ventilator and by doing bagging, and if child is improving, what is that reason?
Ventilator trouble.
First and foremost thing, you should rule out whether the problem is the ventilator, because when you are on the inspirator or cardiorespiratory collapse, you should not troubleshoot on the ventilator. You need to make sure that I am not dealing with the ventilator problem. For that to figure out, first take the child on bag and mask. It's 100% FIO2. If child is improving, it's problem with the ventilator. Now you go and troubleshoot with the test lung or any other lung. Is it clear? So you should not do the testing when child is collapsing. You should do the testing only when you stabilize the child on bag and mask, bag and tube ventilation. You start with bagging, the child is improving, you know that the problem is with the ventilator. So you troubleshoot the ventilator later on. When child will be on the bag and tube ventilation. And even with bag and tube ventilation, even if your child is not improving or you're not getting adequate chest raise, then what could be the problem?
Tube blockage.
Tube?
The tube blockage or we need to check patent.
So tube blockade, it's only tube blockade?
Yes.
Displacement or obstruction.
Displacement of, that's all? You ruled out pneumothorax by just bagging. When you're not able to do the child with bag and tube ventilation, you have three options in front of you. It could be displacement, it could be obstruction, it could be pneumothorax. So how to it's obstruction, displacement, or pneumothorax? No, you should not check with the step at this moment. Even without putting you can differentiate two things here.
Functioning if improves.
Even without any extra equipment, just by bagging, you can tell, you can differentiate two things here.
Resistance when doing bagging.
Exactly. By feeling how much amount of resistance you are getting, you need to decide it is obstruction bar pneumothorax or it is just displacement. So in displacement, what will happen to your resistance?
Less resistance.
You don't need to have resistance at all because it's already displaced into the mouth or esophagus. You can easily bag it. And sometimes you can hear gurgling sounds. So that is what you need to troubleshoot. So the first thing, start on the bag and mask, bag tubing, improvement, it is equipment, gone. So you troubleshoot the ventilator. Next, not improving, whether I'm feeling high resistance or low resistance. If low resistance, it is displacement, take out the tube, put the new tube. Now you are having other side, high resistance. Now you need to put the strength, auscultate whether the air entry is equal on both sides or not. If equal on both sides and you're not getting chest raise adequately, then you need to do the suction part. And you know, the suction still not got improvement, then what do you do?
Suspect.
The air entry is equal on both
Okay.
sides. You did the suction, you cleared some secretions, but still your same amount of resistance you're offering, you are getting.
Increase pressure.
There's no tube kinks. What you have to do
More
is,
with Cambo, more pressure.
yeah, you need to take out the tube, put the new tube, that's all. You should not wait on, I did the suction, I need to keep waiting for the child to improve. No. So if an acute deterioration and you feel that there's a problem with the tube blockage, so immediately you need to take out the tube and you need to put a new tube. So I may be asking extreme question, but sometimes it may be useful for you people also. Even after re-intubating, you are feeling resistance, you are not getting chest rise. Air entry is equal on both sides. You re-intubated with a new tube. Even despite that, you are not getting chest rise adequately and your resistance is very high. And you are not ventilating asthma child. In asthma, you can just compress it and release it. It is not asthma also. Yeah, in asthma it is possible, but it's not asthma. And you've done the chest compression as well. So it is ruled out.
Low complaints.
No, why sudden lung is abnormal?
Patient is generating more pain.
Yeah, then also you at least some pressures you should maintain, right?
Any mucus plug
How
in
bad the
current
lungs
near.
will be, it's not like lungs will become suddenly bad. Okay, pulmonary hemorrhage can cause sudden lung worsening, but you can know, na? It can, it is essentially bloody. Easily you can know that.
Any mucus plug near current.
Where?
Bifurcation.
Exactly. So never ever miss this. It could be a bilateral pneumothorax where your air entry is equal. So you need to get the X-ray done, or you need to put the bedside ultrasound and look for pneumothorax signs. Or if you don't, put the needles on both sides. And if you rule out pneumothorax, bilateral pneumothorax, then the next answer is a block in the bifurcation of trachea. It's not at the level of carina. So how many tubes you're going to change is not going to improve the block at the carina. So what are you going to do now? You're going to tell the child to die?
Deep suction.
Yeah, you tried all the sections. It's not working. Yeah, there is a third thing. You have to do a deep suction, increase the pressure on your suction jar, increase the pressure to maximum, put a wide bore suction catheter, put a bicarb, put a saline, whatever you do vigorous bagging, and you do all these things, and still the child is not improving. Child is collapsing, desaturating, heart rate is dropping. And obviously you don't have bronchoscopy unit. The similar situation you'll face in one condition. Yeah, correct. Someone answered. How to do that? You're going to
Increase in auto peep.
You're going to do this in similar situation like foreign body. You're going to do this in a similar situation like in tracheal foreign body. To save the life of tracheal foreign body, what are you going to do? Tracheal foreign body. Foreign body is in trachea. So what are you going to do? How to save this child of life of a child? This child. No, child is collapsed, man. You will ventilate the child. Child is on IT2. You cannot do Hamlet.
Increase.
Huh? It is in trachea. It is blocking trachea. You cannot ventilate anything.
Visualization and removal.
No, you cannot be telling it's in trachea. You don't have bronchoscopy.
Increase the PIP.
You cannot increase PIP. It's not going to much effect. You are already on bad. Tracheostomy, no. You cannot remove by tracheostomy. You are not expert at tracheostomy. Just think logically. Someone already told. Some of my PD told the answer.
Position.
You cannot do anything there. You need to push it to one side, either left side or right side. You just take some bougie or something, or with the tube, you need to push it, make it go to the one side of the lung. Whether it go to left side or right side, it's fine. At least you buy some time until you get a pulmonologist or intensivist who can come and do the bronchoscopy. So you need to make sure that at least you are ventilating one lung. You may not face this situation regularly, but you should be aware of the situation that if I encounter this particular situation, I need to do at least single lung ventilation. And these measures should be taken when the child is sinking. You don't have much time there. So when a child had a complete tracheal block, you don't have much time. Child will collapse in seconds. You need not give 1 minute time for you. So that's it. In that 1 minute, you need to make sure that you have assessed the situation. You ruled out tracheal ET2 block and pneumothorax, and it confirmed that it is the mucus plug or it's a foreign body which is blocking the complete trachea, and I need to push it to one side. The best option is you take a bougie where you use it for ventilation, and just with the pressure you push down. So it will go to one side. It will go to the right side, it will go to the left side. So you can ventilate single lung. So that is what you are going to do in acute deterioration. So dose pneumonic. So disconnect you, because someone previously told. So in asthma also, because of dynamic hyperinflation, you can have immediate cardiorespiratory collapse. So there you need to just disconnect from the ventilator, just allow for the exhalation, or you can do manual chest compression. With that child improved, it is the breath stacking or dynamic hyperinflation. You need to decrease the respiratory rate, increase the E time, and you need to treat the cause. If the child not improved, then you need to look for whether the child is able to improve with the bag and tube ventilation. With the bag and tube ventilation, child improved, then it is equipment malfunction. You need to do the troubleshooting of the ventilator. And even if bag and tube ventilation, child is not improving. So then you need to look for whether bag and tube ventilation is very easy for you, and there is no ETCO2 trace. If you have ETCO2 monitoring, then you need to tell it is dislodged and you need to replace the tube. And you have high resistance, bag and tube ventilation is hard, then it could be two things. Whether it's ET2 is obstructed or mucus plug, tension pneumothorax, or it could be at a very straight bronchospasm. This is the one scenario where you have sudden deterioration and child is at the moment of imminent cardiorespiratory collapse. You should not just think about the alarms here. When a child is at the verge of collapse, don't think about alarms and other things troubleshooting. You just disconnect from the ventilator, do the bag and mask thing, then decide what is the problem. If child is relatively stable, then you need to troubleshoot him based on the alarms, monitors, check the tubings, order test, X-ray, ABG, then you need to decide. If the child had hemodynamic compromise or not, if the child is having dynamic hyperinflation or not, whether the child is having patient dysynchrony or not, and is it a problem with ventilation oxygen? Gases are showing low PO2s and high CO2s, or ventilator is giving alarming. If ventilator is giving alarming, you know how to troubleshooting. If child is having hemodynamic compromise, you need to optimize the hemodynamics. You need to give fluids, pressures, and you need to make sure that there is no dynamic hyperinflation. The lungs are not overinflated because it's going to compress the heart. It can cause a tamponade effect. And you need to decrease the Peep as tolerated, because the Peep is the one which is going to decrease the preload. So you need to, you can see that. In dynamic hyperinflation, you need to disconnect from the ventilator. You need to do the manual decompression of the chest in emergency scenarios. And or if the child is not that hemodynamic compromised or cardiorespiratory collapse is not there, then you can optimize the ventilator strategy by decreasing rate, decreasing volumes, increasing expiratory time. So you need to make sure that you change the ventilator settings to counteract the hyperinflation. In patient ventilator dysynchrony, you need to make sure that whether the dysynchrony is due because of patient-related problem or ventilator-related problem. So you need to make sure the patient is optimally sedated and you are addressing the underlying disorder correctly. And you need to, if you are not able to do the ventilator dysynchrony, then you need to get an opinion from your seniors. So how to prevent decrease this ventilation synchrony. And finally, if you have low PO2 or high CO2s, you know how to manipulate it. So you need to go back to the yesterday's class and you need to decide how to increase MAP in case of low PO2 or how to increase minute ventilation in case of high CO2s. And ventilation alarm, already we discussed this. So high pressure, already we discussed it. The summary slide for this troubleshooting. The high pressure is because of airway problem or because of the bursting lung, or it could be a pneumothorax. So you should troubleshoot it accordingly. And high minute ventilation. High minute ventilation means whether child condition improved or child is breathing at a very high rate or he is getting inappropriately high tidal volumes. You need to look for that. And if you have low exhaled tidal volume or low minute volume, you need to look for possible air leaks or worsening lung condition. And very few times you get the low inspirated pressure alarm. That is when you have a leak in the system. You need to cut the leak. And the low oxygens, you need to check for the pressure in the oxygen supply, oxygen lines. And low PEEP, it's mainly when you're not able to make the circuit without leak free. That is what you need to check for. So with this, we ended the alarm settings and troubleshooting. Any doubts till now? If there's no doubts, we'll just quickly move on to the PEEP titration. Yeah. How it will be easy pneumothorax bagging will be? Yeah, that's what I'm telling you. Bagging is easy, it is displacement. Then it's not easy only, you're going to make difference between either it is pneumothorax or tube block. If you auscultated air index decrease on one side, most like pneumothorax. But if you have bilateral pneumothorax, the air index will be equal only. So then you do the suction, do the tube exchange, and if you're not able to figure out it's not the problem of the tube, then make sure that you should do the meanwhile you should ask for chest X-ray, and you have to be very ready with the inserting ICDs in both. If you have any doubt, just put the ICDs in the emergency. If child is collapsing, you need to do something. You can't just wait. I need to call for X-ray. I need to call for my consultant. I need to get the ultrasound. No. If you have a doubt that this child is having pneumothorax, you just put the ICD, needle, not to insert ICD. Also, just put the needle and see whether bubbling can happen or not. Child is sinking. Don't wait to confirm the pneumothorax by X-ray. That's what I'm going to tell. You need to make sure you need to apply your consciousness and your logical thinking at that moment, and you are getting high resistance to your bagging. It is not tube block, or it is you exchange the tube, and it could be a possible remote possibility of pneumothorax. Don't wait for the X-ray or ultrasound or the expert to come there, because the child is going to have a cardiac arrest. Whatever you do after that, you may not get out of this. So always in a collapsing child, take your own decision at that moment. Don't rely on others to come and help you. So this is one most important curve we need to discuss, and I need your attention in this. So what is this curve exactly? So it is called PV loop. So in x-axis you have pressures, and y-axis you have volumes. So it is going to depict the changes in the volume with the changes in the pressure. That's all. And I am doing it in the volume control ventilation. So just see here, from the baseline and up to this, so you have like this is called the baseline pressure, or this is called PEEP. And after that, I'm slowly increasing the pressures, and my compliance here is how is my compliance here? This line from this to this point.
Low compliance. Low compliance.
This is the low compliance. And what happened to my compliance here?
Suddenly increase.
All of a sudden, my compliance increased here. And what happened to my compliance here?
Decrease.
Increased. So that these three important things you should people remember. At the starting of increasing pressures, there's a low compliant lung. Once at certain point, again, my complaints very much increased, dramatically increased. And again, at high pressures, my complaints dropped. Now I want to know what is the reason for low complaints here. Now here it is because of your lungs are collapsed. You need to do the work to decrease the surface tension. So once you overcome the surface tension, you little bit open up, because yesterday I shown you the balloon. One balloon is collapsed balloon, other balloon is little bit open up balloon. To do the same work in you need to get the same tidal volume in both collapsed and little bit distant balloon. The work done from the collapsed balloon to make the balloon to the desired size is more than the work done from a little bit distant balloon to the to make it a desired volume. So this is mainly because of surface tension, and when your lungs are in the collapsed state, your surface tension will be more, and you need to do little bit of work to open it up initially. Once you make sure that your surface tension is optimized, then your compliance will be like exponentially will become high. This is the time where your compliance starts increasing, and this is the point what you call as lower inflection point. This is the minimal pressure what you needed for alveolar recruitment. You need to open the collapsed alveoli. Once you open the collapsed alveoli, your compliance will become better. And again, why here your compliance is decreasing? It's not like that. You need to explain it. So why again here your compliance is gone down?
Already distended lungs.
Is over distension. Because of over distension, you are going to collapse the other alveoli. So that's why your compliance is decreasing again. And one more important point, this is the inspiration. This curve is inspiration. This curve is expiration. And see here, at some point when you start decreasing pressure, you recruit the lung, and you're coming down on the pressures, and at certain point of time, suddenly you have drop in your compliance. At this point, your compliance is okay, but there's sudden drop. So this is called upper inflection point. Upper inflection point is the point where when you're coming down on the pressures, where is sudden fall in compliance. This is the upper inflection point. It's very important for us to understand how much amount of PEEP we need to keep. And one more important thing is, why this difference between two curves here? When you're inflating the lung, it is like this. When you're deflating the lung, the curve is like this. Why? See,
surface tension.
Yeah, it is called hysteresis, surface tension. Because the main principle of surface tension, you have this. When lung is already open, the molecules are a little bit far away, so you don't need to give more pressure to keep it open. You need to do more work to open it, but once you open it up, you need to do less work to keep it open. There is a strategy in ARDS ventilation. So I think if people understand what I'm telling here, is it clear? You need to understand this curve. Then only I can move to the next slide. Any doubt? Anyone want to ask the question here, or it is clear? If it's clear, then I'll move on to the next slide. If you don't understand this, I need to ask a question here. What is the PEEP you need to choose here? Say my LIP is around 10, and my this over distension point is around say around 18, and my upper inflection point is around 12. So my lower inflection point is 10, upper inflection point is 12, my this over distension point is around 18. So what is the PEEP? I need to choose. LIP is 10, UIP is 12, that beaking point or over distension point is 18.
Six.
LIP is 10, UIP is 12, over distension point is 18. So it should be less than 18, right? Everyone agree with that? It will be less than 10 or more than 10? Yeah, it is more than 10. It will never be less than 10 here because you already know the lower inflection point. Because if you don't open the lung, how are you going to ventilate? The main concept what I'm telling is you need to open the lung. You need to restore the FRC back. So that's why your minimal PEEP here is at least 10. I think everyone getting my point. Then only your complaints start increasing. Then only you need to have low PIPs. If you don't open the lung, you need to give more PIPs, so you cause barotrauma. Once you start opening the lung with the PEEP, and then you need to do less work there. So the PEEP is never below 10 here, and the PEEP is never above 18 here. Now I need to choose the number in between, and for that I give you a clue that upper inflection point is 12. Right. Answer.
12.
You want 12. Why you choosing 12? Why not 11? LIP 10, UIP 12, beaking point 18. So these are the three numbers I given, and someone told we decided that it is between 10 and 18, and someone told it is 12. So why it's 12? Why not 11? Why not 13?
It should be 10, between 10 to 12. It can be 11 and
Will be between 10 to 12. Okay, why between 10 to 12?
Minimum you require 10 to potency and upper inflection. Beyond that, there is distinction.
Now, for example, if I keep 11, what will happen to your compliance here? No, I'm just asking. If I keep it 11, what will happen to the compliance here?
Optimal compliance.
It will be same as 12, it will be decreased than 12. No, it's just simple. I'm asking very simple questions. Don't get confused here. You have a graph in between you. So you just see the graph and tell me if my UIP is the point where my compliance will start decreasing when I decrease below that. Is it clear for everyone? Now I'm giving a number to you that my UIP is 12. And you are telling that I will keep the PEEP of 11. So if I keep the PEEP of 11, what will happen to my compliance?
compliance will be decreasing.
Same as the first.
Okay, my compliance is going to decrease. Okay, now I'm going to give the pressure at 13. What is the difference between keeping at 12 and 13?
Also, if we keep 11, it will be same as that of 12, sir. Beyond that, the compliance is going to decrease.
There's not major difference.
Yes.
So what is the pressure you're going to keep now?
Fifteen or
11, 12, 13. I give 3 options only for you people. Choose from these 3. Don't get confused. 11, 12, 13. We'll make it simple.
13.
Between 12 and 18.
Yeah. It can be 12 or 13. How to choose that? We'll decide. We'll go to next slide. But it never 11. You understand what my point? Is it clear?
Yes, sir.
So you need to make sure that your PEEP is above your lower inflection point. Is it clear for everyone? Yeah, tell me.
Yes, yes, sir.
I'm telling, don't see that is initial PEEP. So that graph is a little bit confusing there, but you forget about that. I am talking about pressure. The pressure I am talking about is PEEP here. He is talking about PAP also here. Just forget about that. So lower inflection point is the point where your lung is getting recruited, not getting recruited, it's recruited. So you need to keep the lung at least at that point. And upper inflection is the point where you have maximum compliance your lung. So what is optimal PEEP is the PEEP at which your lung have a maximum compliance with minimum pressures needed and without causing hemodynamic instability. I repeat it again. Optimum PEEP is the PEEP where your lung is at a maximum compliance with minimal PIP, with minimal effect on your hemodynamics. If you understand this line, then you will go to the next slide and how to do it clinically. This theory, we already discussed the theory part. How clinically you know what is LIP, what is UIP? How can clinically you predict? So for that, you need to do the PEEP titration. Is it clear till now? Can you move on? No, we have to move on. The timing going up. So this is what we do in PEEP titration. So we'll start increasing the PEEP in steps of 2 to 2. And we're going to monitor these parameters. What is this parameter? What is parameter? It's PEEP. It's not PAP. You're going to monitor. It's PEEP. What is this delta P is here?
PIP minus PE.
Minus P.
No. There's a confusion. So it is PEEP plateau minus PEEP because I don't bother about PAP here. I'm not. The PEEP is useful only for lung issues, not for the resistance issues. So I don't want to take PAP here. So I will take only PEEP plateau into the configuration here. And this delta P is called driving pressure. So remember the word driving pressure. This is the driving pressure is the difference between PEEP plateau and PEEP. And this PEEP plateau and driving pressure we are going to use only for lung compliance issue. It is not for the airway issues. And your compliance. Every ventilator has an option of showing compliance. You need to just check it. And your SpO2 and your vitals. Forget about PAP. I'm not going to bother about PAP. So you start increasing PEEP in steps of 2 to 2. At least wait for 5 minutes. At least minimum of 2 minutes. 5 minutes ideal. If you don't have that much time, at least wait for 2 minutes. Allow the lung to get adjusted to the pressures, adjusted to your PEEP, and make sure that your hemodynamics will be adjusted as well. And you need to you need to push the inspiratory hold button, record the PEEP plateau, and subtract it from the PEEP, get the delta P, note down the dynamic compliance, and your SpO2s, other things you need to record. And you need to make sure that your child is paralyzed. The child should not have any spontaneous effort when you're doing PEEP titration. Because it will be changing. If the child is before 5 minutes, child will be taking more effort. After 5 to 10 minutes, child is not putting effort. Your entire scenario will going to change. That's why child should be hemodynamically stable. Child should be completely paralyzed when you're doing PEEP titration. Can others mute? So we start increase the PEEP in the steps of 1 or 2. I'll do it in steps of 2. and I'm going to give at least 5 minutes time for the lung to adjust and hemodynamics to adjust for the Peep. I'll note down all these parameters. Then I'll start increasing it, and I'll keep noting this. And what you're noticing here, what you're noticing in the P plateau, what is noting in the driving delta P, and what you're noticing in the compliance, and what you're noticing in SpO2. So just follow the trend and tell me. Just follow the trend and tell me. So what is happening to saturations? And one more important thing is, you should not do Peep titration when your SATs are normal. It is useless. So always you need to start at a low pressure. Because low SATs. In oxygen dissociation curve, when your SATs are already above 88 or 90, there is not much change. The curve will be like flat. So you have to keep the oxygen dissociation curve at the slow point. So then only you can easily figure out is there any changes in the compliance or not. It's causing any difference in your saturations or not. But if you keep the saturation on normal side, you don't get much difference. That's why always make sure that your starting SpO2 should be on the lower side, not on the normal side. So that's why I started on the low SpO2s, and I'm able to see the dramatic response, dramatic changes in the SpO2 here. So when I started increasing my Peep, my SpO2 is slowly getting better. And what happened to my Peep plateau?
Increasing.
It's increasing. What is happening to my driving pressure? What is happening to my compliance? What is happening to my driving pressure? It's decreasing. At some point, it's increasing, and again, it's decreasing. What is happening to my compliance here? What is happening to my compliance here?
Increasing.
When I'm increasing the Peep, it started increasing. At some point, again, it started decreasing. Right? It's clear for everyone. Even the driving pressure, it decreased and started increasing at some point. At the same point, my compliance is decreasing. This is what point we're talking about? Decreasing compliance. What point I'm talking about here? Beaking or over distension. Is it clear for everyone? Hey, what man? If I'm explaining this much, I am not getting response, means I have to stop this. It's clear on it.
Yes, sir. Yes,
you
sir.
have drop in compliance, the previous curve we've seen here. When you have drop in compliance, what it is?
Big.
Distinction. I'm not explaining any external concepts. I'm making it very simple as much as possible. I'm taking a lot of time to explain because it's a very important concept. So you have started at certain Peep, you started increasing, and your compliance is increasing at certain point. What is the LIP here? What is the LIP here? LIP, what is the Peep here? What LIP point for Peep here?
8.
It's 8 or it's 10?
It's
10.
10.
Because your driving pressure is unknown.
Pressure is
So you have a compliance and your driving pressure is low. So that is the point. Roughly you keep it is a LIP. It could be 9 also, but in this graph, it's around 10. You make it simple. 10 is the point where you have a maximum, almost like maximum compliance with low driving pressure. And from here to here, there's not much difference. But your compliance is very high here. The point 16, your compliance is very high. But your lungs start increasing, recruiting at this point. Is it clear?
Yes, sir.
See here, this is the recruitment point, and your compliance is maximum here. Understood? At the starting of your recruitment, you don't have maximum compliance. but you can able to see some improvement in the compliance. So this is the point of LIP, and your maximum compliance is here, not here. And once you cross that, you have again your compliance is dropping. So 16 is almost near, 16 or 18 is almost near to the over distension point, and 20 is definitely, it's 18 and 20 is almost, it's like a over distension. You don't agree with that? 18 and 20 is over distension. You don't want to cross it. So my optimal PEEP is between 10 and 18. So my optimal PEEP is between 10 and 18. So now I need to determine what is UAP here. So can anyone answer what UAP here?
12.
UAP is 12. Why you're telling it's 12?
The maximum cost.
No, you don't need to have maximum compliance. That's what I'm telling. Because you see the graph here, it's almost same. There's nothing much change in compliance here. So it is, you don't, but once you go below UAP, what is happening to your compliance?
Decrease.
Decreasing. So it is somewhere around 10 to 12. So because you fixed LIP at 10, you can take it as 12. But if you fix LIP, because why not done 9 here? If it's LIP is 9, I can even consider 10 and 11 here. Everyone agree with that?
Yes.
So you can see here, what is the driving pressure here at point of 8 here? What is the driving pressure at point of 8 here? PEEP of 8 here and PEEP of 8 here.
10 and 8.
Why the difference? Why the difference? What are the complaints here? What are the complaints here? What are the complaints here?
Compliance improved, sir.
Why the difference? Because same PEEP here, same PEEP of 8, same PEEP of 8 here. There's no change in PEEP here. Then why the complaints improved?
So,
Yeah, it is because of hysteresis. You are on the deflating curve. You're not on the inflating curve. You started on the inflating curve. You've gone back. You've seen the over distension, and you're coming back. You are on the deflating. So it is difficult to open the lung, but it's very easier to keep the lung open. So if I don't do this, I stop at here. What will happen? I start recruitment. I stop at 20. I will not see this. So what is the PEEP I need to put now? If remove that, it is 14, 12, 10, and 8. Just to stop here. And with only from 6 to 20, if you've done the PEEP titration, what is the optimal PEEP here?
16.
16. You agree with the 16?
No.
I marked it. The answer I marked. I marked it at 14. So I need to have the minimal driving pressure. I'm going to change the statement again. The previous statement I given the previous slide is little different. Optimal PEEP is the PEEP where I get maximum compliance with the lowest driving pressure with minimal effect on hemodynamics. Is it clear now?
Yes, sir.
The point where I have maximum compliance with the lowest driving pressure with no effect on hemodynamics. So according to the statement, your answer here is
14.
14.
exactly. But that is not correct. That's why you need to come down. You need to come down. You have to go you need to take the child on the deflation curve. So you need to see where you get the minimal driving pressure. What the minimal driving pressure here is 8. So on the deflation curve, you are all getting 8. And where you got the maximum compliance?
12.
12.
It's around 12. And you have done, the hemodynamics are not much difference. All have same hemodynamics. So what is the optimum PEEP here?
12.
12. Even it could be 11. I'm not going to argue here. But if you tell 12, I'm happy. So you can. So is it clear?
Yes, sir.
That is recruitment. And by increasing the PEEP, you are doing the lung recruitment and you are knowing what is LIP, UAP, what is optimum PEEP and increment. And one more important thing you need to know is doing this test at one point of time is not going to tell what is optimum PEEP for next 3 days. Because in ARDS, your lung may be worsening or lung may be improving. So you cannot keep giving same PEEP at 10 or 12. Because I done the PEEP titration, I find out what is UIP. I going to give only 12. If child is deteriorating or child is improving, I'll keep at only 12. No. So with the change in lung compliance, you need to change your PEEP strategy. You need to decrease or increase PEEP, and you need to change your what is optimum PEEP for that particular lung, not for that particular day. It's never particular day. You need to keep titrating the lung PEEP titration for that particular lung at particular point. It's not for the whole day or for the whole ventilation. Clear?
Yes, sir.
Okay. If no doubts, we'll end the session here.
Sir, on increasing PEEP, if we get any hypotension, we need to stop that, sir.
Yes. If, for example, I have two pressures here, 10 and 12. My driving pressure is same. My compliance is almost same. And with 12 PEEP, I have an increase in heart rate, drop in BP. So what is the optimal PEEP now?
10.
What's up? Just remember this point. Optimum PEEP is the PEEP where I get low driving pressure, maximum compliance with minimal effect on hemodynamics. These three should be met. It's not only one met. Three should be met. So that is the, and there are certain lungs where you cannot recruit the lung at all. They are unrecruitable. This PEEP titration will be beneficial in recruitable lungs like pulmonary edema, early ARDS. But in late ARDS and non-recruitable lungs are severely damaged, you cannot get benefit by PEEP titration. So when you are not able to get benefit by PEEP, you should not keep increase the PEEP pressures. So you need to do other strategies like proning, other things can help the child. HFOV. Even in HFOV, if your lung is not recruitable, it will not going to get benefit in HFOV also. But you can limit the lung damage by just giving low tidal volumes through HFOV. We'll discuss in HFOV later on. So when you're not able to recruit the lung, you need to do other strategies like proning and HFOV, not just keep increasing the PEEP to maintain saturations. Is it clear? Can I end this session here?
Yes, sir. Yes, sir.
Okay. Thank you.